Welcome to Roadmap to Residency, Evidence-Based Application. In this video, we will be discussing about maternal and child health. So, these are the steps to follow in the prenatal care. Number one is immediate assessment for any emergency signs. For example, unconsciousness or convulsing, vaginal bleeding, severe abdominal pain, if the patient is looking very ill, severe headache with visual disturbances, severe difficulty in breathing, dangerous fever, or any severe vomiting. Then we need to make the woman comfortable. Greet her, make sure she is comfortable, and ask how she is feeling. If first visit, register the woman and issue a mother and child book, that is an antenatal record form. Then we need to assess the pregnant woman. At first visit, we need to write down how old is the patient, past medical history, objective history, alcohol, drug, or substance abuse. Ask about or check a record for prior pregnancy, convulsions, stillbirth, heavy bleeding, prior cesarean section, forceps, or abortion. Then we need to assess the pregnant woman. On all visits, we need to check the duration of pregnancy. We need to ask for bleeding, danger signs during this pregnancy, check record for previous treatments received during this pregnancy, prepare the birth and emergency plan, ask patient if she has other concerns, give education and counseling on family planning and breastfeeding. We need to assess the pregnant woman on third trimester by a Leopold exam. We need to hear the fetal heartbeat, and we need to give education and counseling on family planning. Do not perform vaginal exam as a routine prenatal care procedure. Always record the findings, and all pregnancies are at risk. Encourage all pregnant women to deliver in the health facility. Refer the patient with abnormal findings to higher facility. Get baseline lab information of the woman on the first or following the first visit. Example, hemoglobin, blood type, urine analysis, VDRL or RPR to screen for syphilis. Then we need to check for pallor or anemia. We need to check for hypertension or preeclampsia. We need to measure the BP in sitting position. If the diastolic BP is 90 or higher, repeat measurement after 1 hour. If the diastolic BP is still 90 or higher, ask the woman if she has severe headache, blood vision, epigastric pain, and we also need to check for urine for the protein. Then we need to check for gestational diabetes. We need to ask about the family history of diabetes and history of the obesity. We need to ask about the past pregnancy for difficult labor, large babies, congenital malformations, and previous unexplained fetal death. We need to look for the sign of maternal overweight or obesity, polyhydramnios, signs of large baby or fetal abnormality, and vaginal infections. We need to check in for any fever, burning sensation of urination, or any abnormal vaginal discharge. We need to ask about the episodes of fever or chills and take the temperature. We need to ask about the pain or burning sensation. We need to ask about the presence of abnormal vaginal discharge. We need to immunize against the tetanus. Now, these are the different doses of tetanus that we want to give. We need to give mebendazole to treat for any intestinal parasites. This is just just our prophylaxis. We need to give iron and fluid supplementation to prevent anemia and needle tube defects. And we need to we need to refer for preventive intermittent treatment for falciparum malaria if the area is endemic. We need to provide health information or advice for nutrition, self-care during pregnancy, effect of tobacco, alcohol, and drugs, breastfeeding, birth and emergency situation, and schedule of appointment. Then we need to advise on danger signs via vaginal bleeding, convulsions, severe headache, severe abdominal pain, fast or difficult breathing, fever, or burning urination. We need to encourage the women to come back for return visits. At least 4 routine antenatal visits are recommended by WHO. First visit should be before 4 months of pregnancy. Second visit should be at 6 months. Third at 8 months, and fourth at 9 months. Return if undelivered within 2 weeks after the estimated date of delivery. So these are the key messages for antenatal care. We need to reduce the number of visits. There should be a skilled birth attendant. There should be screening and prevention of diseases that may complicate pregnancy. There should be preventive measures, for example, tetanus immunization, iron and folic acid supplementation, counseling on family planning, nutrition, breastfeeding, and danger signs, birth plan, birth preparedness, and complication readiness. So talking about the child mortality rates and definitions. So the neonatal mortality rate is the number of deaths during the first 28 days of life per 1,000 live birth. Infant mortality rate is the number of deaths during the first year of life per 1,000 live births. And under 5 mortality rate is the number of deaths during the first 5 years of life per 1,000 live births. The under 5 mortality rate includes both the neonatal and infant mortality rate. This is a simple example of rate calculation. So for calculating the good death rate, we need to have the number of deaths in a given year by reference population during the midpoint of the year and multiply it by 100,000. Here is a basic example. So crude birth rate, also by the same method, number of live births within a given period by population size at the middle of that period into 1,000 population. Infant mortality rate is calculated by the number of infant deaths among infants is 0 to 365 days during the year and number of live births during the year. So into 1,000. Now this will give you the infant mortality rate. The neonatal mortality rate, number of infant deaths on 28 days of age by number of live births into 1,000 live births during a year. This will give you the neonatal mortality rate. Now the post-neonatal mortality rate. So number of infants deaths from 28 days to 365 days after birth. Number of live births minus neonatal deaths into 1,000 live births. Now this one is typically important because you need to subtract the neonatal deaths. Maternal mortality rate is the number of deaths assigned to causes related to childbirth by number of live births into 100,000 live births during a year. Now these are the recommended vaccination schedule for the different ages of children in the United States. You need to remember this by heart. So because there will be many questions, especially in the USMLE Step 2 CK unit examination. Now let's talk about reproductive health. So WHO defines reproductive health as a state of complete physical, mental, and social well-being, and not merely the absence of reproductive disease or infirmity. Reproductive health is a fundamental component of an individual's overall health status and a central determinant of quality of life. So what are the different elements of reproductive health? The access to quality service to management of complication for unsafe abortion, post-abortion family planning and counseling, access to quality of family planning service, prevention and treatment of reproductive tract infections, including sexually transmitted diseases, management of menopause, facilities to receive referral for infertility and all morbid conditions related to reproduction, appropriate sexual and reproductive information for adolescent, and elimination of harmful culture practices. Now, these are the different reproductive health indicators: total fertility rate, antenatal care coverage, low birth weight prevalence, prevalence of anemia in women, availability of basic essential obstetric care, contraceptive prevalence, maternal mortality ratio, perinatal mortality rate, and prevalence of infertility in women. Now, these are the global strategy for women's, children, and adolescent health that the WHO has suggested to be improved within 2030. Survive and preventable deaths. Thrive, that is ensure health and well-being. Transform, that is expand, enabling environment. And leave no one behind, that is cross-cutting. Thank you for watching. Studying.